of the imaging research I've done in tobacco use and the side paths and some of the things that we've messed around with, I'll avoid because it's distracting mostly. And is there a pointer thingy? Okay. All right. So just quickly, this work really began when Karen came to the BBL and presented her tobacco research and engaged us in applying some of the imaging methods that we were doing there. And what I'm going to talk about exclusively is task bold imaging. There's a lot of other things that were done and are doing, but I'm not going to bring those up here. And then, so the crew at CERNA was obviously involved in the tobacco work, the folks at the BBL, and I have existing collaborations with the Center for Studies of Addiction, and these are long-standing, right? And Anna Rose was actually there for some of it. Yeah. So I hope that these, are now facilitated even more. So I won't spend much time on this, but I'll give you the highlights. Tobacco combustibles are bad for you, and you shouldn't do it. And people that do it get sick, and they get sicker than we thought. And so that's one thing. Trying to quit is hard, and there are a lot of reasons people complain about failure, and I can talk more about those. Young people are smoking less. Everybody's smoking less. One of the reasons you're smoking less is, could you imagine in this room 20 years ago, half of you would be smoking right now with some ashtray there? Can you get on a plane and imagine people smoking next to you or actually smoking? It's crazy. That's what we used to do. You watch this stuff on TV and the movies, you're like, what are these people thinking? But young people, they still are susceptible to bad ideas. And just because they're different forms of nicotine delivery doesn't mean that combustibles are going to disappear. Because, first of all, I have two 15-year-olds and they have terrible ideas all the time. And predicting what their terrible ideas are is very difficult, impossible. And also, these things come in cycles, right? So now, like, everybody wants to buy vinyl. Why? As soon as everybody's going to want to go back to good old combustibles. You don't know. You can't predict what it's going to be. So, and then we've had people that are hanging on that are they're having a lot of trouble with it. And, so those folks tend to smoke more. They're older. They're unhealthy. They have other health issues in addition to smoking. So that's a good reason to keep doing this, I think. And we know some more things about it that are helpful. So what do we know? Well, I'm going to talk about it on the next slide. So the story that I'm going to tell is about working memory. And when this was described to me, that people try to quit smoking and they complain about problems concentrating, attention, fuzziness, particularly acutely, my reaction to that was so, like, what? Like, there are all these other things that seem so much more important, like dying to have a cigarette, like physical withdrawal, craving, cue, having cues trigger relapse, having stress trigger relapse, having opportunity, right? There's nothing worse than like sitting next to your friend who's doing whatever, eating carrot cake. So that's kind of where this program went. It tried to look at what is going on with working memory deficits, particularly in terms of brain function. What happens when you treat it with pharmacology? We talk about that. And then what are these things going to tell us about how well people quit? Or a better way to think about it is how they relapse, because you get a lot more of those, right? It's easy. It's a bigger group. So this is what Karen showed when she came over and gave her presentation. And this was 2008. This is like, how long? 12 years. It's ridiculous how long this has been going on. So she had some folks that had done a working memory task, and it showed that there was a difference in performance under abstinence. And shocking, the worse you are at it, the more you're likely to relapse. So this is the kind of thing that seems obvious. The sicker you are, the worse it is. But you have to decide what it is to measure, right, to know. In addition, on a self-report, through some of these ADHD scales, folks complained about this fuzziness and these problems with attention. So Karen asked nicely if we would be interested in taking some of our working memory tools that were developed at the BBL and had been studied in healthy people, normed in healthy people behaviorally, and then applied in neuroimaging, PET, and then old fMRI, and had been used extensively in folks with schizophrenia, which is where I was, happily working with folks with schizophrenia. But to be honest, looking at smokers was pretty exciting because they get better. If you can get them to quit, it can really improve the health risk. The risks go down. So this was pretty exciting to get involved in. So how did we do it? Well, there are a lot of different ways to measure working memory. The one that we developed there, it was important that it be nonverbal. So some of these tools use letters and words and numbers, and we used a visual end-back task. So these fractals are generated by some really simple program, makes random fractals that you can then choose nice-looking ones and make a working memory task. And I don't know how many people are familiar with this. This is an extremely annoying test to take. I don't know if anyone's ever done it. This is what we call zero back. This is a target. You see it, you push the button. So I usually do pretty well on that. And then it gets worse. You have to wait around and look for two in a row that are the same. So now you're monitoring the environment, but your working memory demand is low. It's not as low as target detection, but it's low. And slowly we can ramp up the demands on working memory. And the next instruction is the one before the previous one. So you're waiting, you're keeping things rolling in your memory, and you're monitoring several trials back. Okay?
That's why we call this the horrible impact.
Right, exactly. And then you can go 2 back, 3 back, 4 back, and when there was this big thing with the cognitive training, what was that thing called? Lumosity. Everybody was like trying to practice their working memory, and some people got the 9 back. You know what it does for you? Stop. Right? When do you use working memory? Does anyone have any idea? I'll give you an example that again is really dated. Back when we had landlines, you have to look up in the phone book the pizza place, and you look up the pizza place number, and you read it, and then you walk over to the landline and you dial. That's you're keeping it actively in your working memory. What happens when you get interrupted by somebody who wants to know how much beer to get? You forget it because you haven't actually encoded it. It's not in your memory. It's only available while you're rehearsing it. Another example for Janet, when you're at a traffic light and you're in a school zone and you stop, you've been going 50 miles an hour, you stop at the traffic light. Now the light goes green and you take off because you've forgotten that you're in a school zone because it's not actively being rehearsed. You get a warning, right? Okay, so what do we do? Okay, so here, this is the first study we did, and I'm not going to focus on the genetics of it because, interestingly, Karen and I had a very heated discussion at our first meeting about whether we were going to look at genetics or not. And so, anybody surprised that I lost? So we did include this candidate in the COMT candidate in the study, but that's not the take-home message here because we didn't really pursue it. The message here is that when you get into higher levels of working memory demand, as the load goes up, you begin to perform poorly. When you're abstinent, right? Because smoking is a normal state. So if smokers smoking, they feel great. They might even be a little bit better. You know what I mean? They get a benefit from nicotine, perhaps. It's probably not worth it, right? But when you put them into a withdrawal state, and it can be 72 hours is where we started, and then we slowly reduced it. Now we're like 24 hours overnight abstinent. You come in, and you have enough of those changes in your attention to feel it and also perform poorly. So that was the beginning, where we saw that folks were performing poorly, and there's a change in the working memory system in old fMRI. So we know how working memory challenges the brain. We have it well mapped out from the work at the BBL and healthy folks. We expected it to be both left and right dorsolateral prefrontal cortex. The visual piece, right? This visual piece was developed to lateralize function and show that when you use verbal tasks versus visual tasks. You rely more on the right hemisphere versus the left hemisphere. My collaborator Dan Ragland wrote a great paper on it. It turns out it's actually really small and really hard to notice, that it really drives both right and left dorsolateral prefrontal cortex. And of course, like ACC and their parietal attention network and a bunch of other stuff, if you look more broadly. But what we focused on were sort of the task positive regions in dorsolateral prefrontal cortex and the cingulate gyrus, ACC, and also the deactivation that we see in the posterior cingulate cortex, and also some frontal deactivation. So this was the beginning. What do we do next? I'm not sure. I have to look. Okay. We did it again, which is always good, right? You do it once, and then you ask for more money to do it again, and it worked out well. So, and also in fMRI, half the time you do it again, and then it's not even anything close to what you did the first time, especially when you have small sample size. So the first study was small sample size. The next one is a decent sample size, 63 folks, and we used this paradigm that Karen and her folks developed, which is great. You have this order effect problem with cocaine, opiates. You bring people in, you study them while they're actively using, you detox them, you get them off the drugs, and now you study them again. Well, what you really should do is then get them back on the drugs and study them again. But it's hard to get approval for that, right? So what we did is we developed this practice quit attempt, which means folks come in under acute challenge. They've been abstinent for 24 hours, 72 hours. They do the study, or they're smoking. We counterbalance it. We collect the data. We send them out there. We say we're going to set up a target quit date, X number of weeks after your practice quit attempt. Everybody's happy with it. IRB's happy with it. Participants are happy with it. And then they come back for their quit attempt where they're supported, and we monitor what's happening while they're trying to quit and when they're abstinent. Okay? That solves a lot of problems in neuroimaging. And that was really one of the reasons I thought, okay, this is a group that knows what they're doing, and they're thinking ahead about how this stuff can interact with the order effect, particularly with BOLD. And you keep measuring fMRI, and the signal just keeps changing no matter what you do. It goes down, basically. Okay, so we got it again. We're pretty excited, and so this task is really nice. You can make the working memory progressively harder. Then you can model that. Then you can say brain regions that show sensitivity to increasing load. That's where we're interested. You get a very nice map of it. And then we see the signal there begins to differentiate under abstinence versus smoking as stuff gets harder. And 3-back, it's kind of painful, but it's not impossible. It's actually quite hard for patient populations, but in smokers, 3-back, it's got to be there. You really got to push the system. So what happens when you treat people? This is, a real test. So why do people on varenicline, why are they doing better? Is it only the craving? Is it only the withdrawal symptom management? Or is there a role for working memory? So here, in an intervention with varenicline, we saw that the working memory performance and brain function really is restored to what looks a lot like smoking as usual, right? So on the drug, on the drug, on the drug, not so great. You have this drop at 3-back, and abstinent, no drug. On the drug, looks like you're smoking, right? Which in a smoker is the way they want to be. Now, on a side, so we did another study where we thought if we changed dopamine levels in prefrontal cortex using talcopone, which is a compound for Parkinson's. It's not benign. It was a lot of work to do. So we got these folks to come in, we put them on this drug, it has some side effects. They tolerated it okay. We put them through the same protocol, and nothing. They didn't change their smoking behavior, and didn't change the working memory behavior, didn't change working memory signal. So this is a positive, and there was also a negative, which in some ways is we weren't so happy about, but in the long run, it's helpful to know. The story doesn't always work out. okay, so at the end of this series of studies, we said let's do one where we get a large sample, we have everybody's in the same sample, consistent. We thought about putting pharmacology into it, we decided against it. What we really wanted to know is, what is it good for? Why do you want to go through this? Why do we want to have the brain signal? Is it going to help us in any way? And mostly we're interested in, does it help us tell whether you are going to fail or not, right? Would it be helpful to have somebody come in and say, the chances of you succeeding are really bad because we measure your brain and it looks bad for you. So that was my idea for a clinical intervention. And probably people said maybe a different way would be to say, it looks like you're ready to quit, or it looks like you need support to be successful. And we know that because we've looked at your brain and we can see that there's an area that you need support in, which is working memory. Okay? So that's what this R01 was really about. And it was large and the sample size was decent, around, I think that depending on which way we looked at it, 90 or so, or you know, from 70 to 90. And it was complicated, as you can see this description at the bottom. I mean, I don't even understand what some of that is. But folks came in, they did this quit attempt, counterbalance quit attempt versus smoking. Then we put them on a protocol where they quit. We were really interested in 7-day quit, right? Because it turns out that that's enough. Like folks that fail, it's like a hockey stick, you know what I mean? People are like, oh, I'm doing great, day one, and then it's a slow kind of drop off after that. So in those first 7 days, you learn as much about as you do in 6 months. And Becky here? Becky wrote a nice paper about that. And then, so now the question is, what is it good for? Well, what we really wanted to do is to take this brain information, let's just think of it as another measurement, and say, does it improve our ability to predict outcome? And so I see it as 3 different categories. You got this, people come in off the street, you ask them a bunch of questions like, how old are you? Sex? How much do you smoke? And then you make a decision about what is their risk of relapse, right? That's pretty lousy. And it's very low cost, so it makes sense, right? It's easy to do, and it's useless. Like, that seems to be some correlation there. The next one is harder. If you look at some of these self-report measures like craving, withdrawal, mood, and stuff that you can measure while they're abstinent, now you've got them in a state where they've changed. They're in acute abstinence, and you learn something from it. Because the more withdrawal, the more craving, the worse they're going to do. But it's not great. It's not so good at predicting outcome. So what if you rolled into that the brain signal? And so the high cost of the highest cost is doing all this stuff, abstinence and the brain signal. The next step would be you bring them in and put them under abstinence, but not do the imaging. And then the last thing is they walk in the door, you ask them some simple questions, and then you know everything you need to know to treat them, which would be ideal. So those were the 3 models we were thinking about. So when we looked at it, the effects that we saw that were predictive were in the left dorsolateral prefrontal cortex, a place we've seen a lot, right? We've been seeing these plots of that being sensitive to abstinence. Turns out that change from smoking to abstinence in that region is predictive of outcome. And so that was kind of what we were hoping for, right? So that's a task active region. Another region that actually maybe was more predictive with changes in deactivation in sort of this resting state network, which goes negative when you engage in a task. So the posterior cingulate was also predictive of outcome. And then behavioral measures, like what is it that's under abstinence that you can report what's making you crazy? Withdrawal, so the withdrawal scale. Those 3 items were best at building a model that predicted relapse, 7-day relapse. So we threw other stuff in there too. There were different strategies we used. This is straight regression models, but we also did some bootstrapping to see which would float to the top. The same sort of variables kept coming up with different methods. So then finally we did Paul Boletto, who never over here anymore. He worked on an RC analysis to see sort of how these different models perform in prediction. And so you can see the red line is sort of like, come in and tell us all about yourself and we'll tell you like how you're going to do in your quit attempt. And the next is the non-imaging measures under abstinence challenge. So now we've invested something in getting you off nicotine for a period of time. Come in and tell us how you're feeling and we'll tell you how it's going to turn out for you. And then when you throw in the brain measures, you can improve that model of prediction on whether somebody's going to be quit after 7 days. Okay, so this was sort of the outcome of the study. We were pretty happy about it. There was a significant difference between the brain imaging model and the clinical model. There is not a significant difference between the brain imaging and the measures under abstinence in terms of the predictive ability. But we had problems, of course, there are always problems, right? So one of the problems is sample size, right? So the sample size is small. We were limited in what we could do. We couldn't do any machine learning. We couldn't do sort of advanced methods. So we were a little bit unhappy about that. Let me go speed up a little bit. Okay, so what were the limitations? You know, when you do these models, you build a model, and you build it, and you test it on the same population, and God, it works great, right? So of course it works great. You just built the model with what you're testing it on. So there have to be some validation methods, and in this case, we used the leave one out approach, where you keep building a sample sort of randomly, and you see how you do on what would be a test sample outside of the model generation. And that was, there's always like shrinkage, there's always a reduction in your predictive ability. It was within what was expected. It was lousy for all of them. They all decreased in their ability to be predictive. Brain measures were no different. One of the problems we had is people fail a lot, right? So the quit attempt was supported, but it wasn't supported with any pharmacology, and it wasn't important. We didn't really do all we could to help these folks quit for 7 days. So maybe we should have done more. And then we would have more folks that succeeded, and that would help us build our model with a more balanced sample. It's a sort of a dichotomous outcome. We tried some continuous stuff about cigarettes over the 7 day period, but basically, either you quit or you didn't quit. And then you have so many people that didn't quit, it would be nice to bump the number on the other side, at least for the 7 days, at least push the hockey stick a little bit. So those were some ideas that came up. And then, so is this short-term 7 days really the best outcome? I think that investing in the follow-up is a good idea, but it's not necessarily going to teach us that much, okay? So what about all this other stuff? We know that stress affects the brain and is different under abstinence. People are more sensitive to it. We know that cue reactivity is different. So why are we focusing only on working memory? Exactly what we said in the next grant. Why are we focusing on working memory? Why don't we build a model that includes other things? And this is the model I call the milk stool model of relapse. It hasn't gone anywhere. It's the three-legged model. So there are 3 legs to relapse. There's the working memory piece, which we've kind of explored, but there's also the role of cue reactivity, and stress. And in my sense is that these all play a role at different times in the quit cycle. So acutely, you're really sensitive to these changes in working memory, and cues and stress, but you're most likely to go out on the stuff related to working memory. And then as you move on in your quit attempt, the others may come and be more important. So what we proposed is to look more carefully at this model, and that's what we're doing now. So we're going after a larger sample size, which is now 100. Cecilia is like 115, 116, and growing every day, right? And so we're going after more folks. We're measuring stress with a stress paradigm. We're measuring cue reactivity with some nice cues that we borrowed from someone. We have a new cue paradigm that I think is going to be more productive, give us better signal. And then we're doing, of course, the working memory. So now we hope that we can build in one sample, a larger sample, an integrated model, test this integrated model, and look at how well it does in predictive outcome. And so what do you do with that, right? Are you going to bring people in and image them and tell them whether they should quit smoking or not? Yes. The answer is yes. Why wouldn't you? Because the cost is coming down. There are many ways to scan folks that are less invasive. Whatever would help, helps. And as you said, this should teach us a lot about other substances that are used. So our hope is that, yeah, this will begin to play a role in treatment. It certainly would guide intervention development. And I think that in the long run, this model that integrates all three will have a role in helping identify folks, not only that are ready to quit, but where do they need the support? Maybe they don't need the support in all three. Maybe they need the support in one of the areas. Okay? Am I out of time?
Yeah, we're giving it.
Okay, I'll take one question.